Good afternoon, and today we have a pleasure of interviewing Dr. Carlos Flores-Mir. He's a professor of orthodontics in Edmonton, Alberta. Good afternoon, doctor.
Good afternoon, I guess, Maria. Thanks again for having me and giving me the opportunity to chat and then discuss together some interesting topics that we're facing day to day.
And thank you very much to our audience. If you have trouble sleeping or sleep next to the snoring partner, this program will help you to broaden your horizon. If you're a medical professional who's very passionate about topic of sleep and facial development, and just like us trying to put all missing puzzles together, this program gonna give you a lot of answers. And again, thank you very much for listening. We really appreciate your support, and please put it in the comments. And I'm going to put information about Dr. Carlos Flores-Mir underneath this interview. And just one fun fact, what I'm so impressed, Doctor wrote 460 articles over his career. He's an extremely smart and prolific writer. But I'm going to start with formal introduction. Just like I mentioned before, he's a professor of orthodontics in Edmonton, Alberta, but he actually started his medical career in Lima, Peru. And then he moved to Canada, and he's a director of graduate studies and director of graduate orthodontic program. He's also practiced part-time as an orthodontist, so he sees both worlds. And he's also editor-in-chief or editor of a lot of orthodontic magazines. And that's, that's not only he has his own views, he actually look at the other people's views and edited that. So that's the amount of knowledge. I personally met Dr. Flores-Mir at PANI at the conference, and I was really impressed with his level of knowledge and his view. We talk a lot about present state of orthodontics and how it affects sleep of present and future generations. And right now, it's a lot of divide between practitioners, orthodontists who graduate from orthodontic programs, and general practitioners who practice orthodontics with a different eyes, totally different eyes, because they see the result in a long-term frame of their patients, and views are totally, totally opposite. But it's very exciting to have a academia look, all the scientific research, what we're going to discuss today. And I'm going to ask with a specific question. We talk a lot about importance of breathing through the nose. And I want to know your opinion, Professor. How do you think, nasal obstruction or inability to breathe through the nose affect the result of orthodontic treatment? And what orthodontists should or should not do in that sense?
Oh, thanks, Maria. So I think first we need to understand not to overstep outside of our scope of practice. In other words, as a dentist, right, we're supposed to understand, manage conditions inside the mouth, but we need to understand things around for sure, right? But then we need to be careful not to pretend to do diagnosis of a problem that is not necessarily oral. So my first reaction to a conversation about nasal obstruction would be, ideally you have a physician, better so an ENT, to actually assess potential causes of the obstruction, right? For example, it is quite common that the obstruction is because of an inflammation of soft tissues, right? The terminates, for example, right? And so, yes, the orthodontic treatment could indirectly provide more volume, more space, because if we use an appliance like an expander, palatal expander, by expanding the roof of the mouth, by default, you're expanding the base of the nose. So I don't think there's any controversy regarding the fact that an expander increases nasal volume, right? But the question is the solution of a problem from the medical point of view really about increasing the volume, or we should address the hypertrophic turbinates? And so the real question, and we don't necessarily have clarity, is does, for example, an expander reduce inflammation, right? Just because you increase the volume, if you don't address the cause, it may help, but not really help. And I think that's kind of where interdisciplinary treatment comes. So in summary, I think that orthodontics can have a role in helping with dealing with nasal obstruction problems, but it should be as part of a team where the physician tries their pathways to solve the problem and then thinks that increasing the volume may help. And that's where we can go and play.
But I want to ask you this question vice versa. Like,
Okay.
do you think nasal obstruction affects craniofacial growth?
So the question then becomes because then sometimes we have what's called acute obstruction. So in other words, patient gets a fever, gets a virus, something. So actually the body reacts and then the tissues around the nose, the pharynx, hypertrophy, and it's just to try to address that. So I don't think that an acute inflammation event per se requires really, we should not be thinking about craniofacial impact. If it is chronic, and I'm not sure we have a definition after a month, 2, 3, 6 months, I think eventually the longer it is, the more likely it is that to some degree may be a factor to consider in altered craniofacial growth. Probably the complexity of the body is such that even if you have 2 kids with the same level of chronic nasal obstruction, in one of them, actually craniofacial growth may change, but in the other one, not at all, just because the body is able to overcome that. So I think that's the complexity of this topic, that there's not one solution for all, right? How we identify who it's more likely to benefit from an orthodontic intervention to address the problem and who will not really benefit, it's a big question. And we are not there, and that's called individualized or personalized medicine. We are not there yet in the realm of OSA and pediatric OSA and orthodontics.
But I'm wondering, the level of research in Edmonton University, what, in a sense of AI, what are actually happening to develop the personalized pathway, orthodontics, factors what affect craniofacial development. Tell me what can be in the future, what we as a practitioners have to, look for.
So probably then we need more research where actually an orthodontist or a dentist with interest in orthodontics and an ENT or a physician actually work together in the diagnosis of these cases. Actually, then you provide an orthodontic intervention and then both go, because as orthodontist, I know that I will be able to increase upper airways. That's logical, especially in the nose. The question is, does the increase in the volume of the nose or the nasal cavity have a real life impact on the patient, so function? Then, well, we are not necessarily, it's not a scope of practice then to make that call. It has to be a physician or ENT to actually say, you know what, really, that expansion actually did generate a positive outcome for the patient. So we need the ENT to confirm or actually tell, great, volume increase, but sadly, in this specific case, that increase of volume did not really help the breathing function of the patient, because these are complex chronic inflammation problems. So the problem is just not there. Probably this patient has inflammation in other places. So if you solve one of the areas, but you don't solve the other areas, in the big scheme of things, it may not matter, but in some patients, it may make a big difference.
No, this is a great view, but very confusing. It's so much easier to have a clear-cut answer. So you do this, then this happens. But I think we don't have the luxury of that.
I think we all will like simple things. Like we all will like to have an answer that say, if we do A, we'll solve B. But that doesn't work in any field of medicine. So we should not be surprised that that's not the case in orthodontics or pediatric OSA, right? As I say, at the end of the day, also, dentists, we need to be aware that the diagnosis of the problem or the diagnosis of the solution of the problem, it is not up to us to make the statement. It is the physician that needs to, until the scope of practice is changed. And I don't see that changing pretty soon.
No, that's all true. But I would like to ask you, in studies, when I look through your articles, study by Vidigal. It's explored the link between craniofacial features and the presence and severity of sleep apnea. Like, you participate in that study. What a takeaway from that study? How, looking at the
Actually, I was one of the reviewers of the study. I was not an author. So I think there's different ways to look into the data. So that's been recently published in Sleep, right? And basically, it's when you look into, they actually assess a lot of measurements in the face, right? And they identify a few, 3, that were actually linked to their disease, OSA, and the presence. And so you can look into these different ways. So the authors look into these 3 and make the point that, look, there are 3 variables that are linked to, but I can also go there and realize, well, you measure 25 variables, you identify 3. So that actually, from my point of view, explains the complexity of this, right? Because then the authors even measure several things from the mandible, but only one of the variables was linked to OSA. So I think that what my personal view at this point of time, and these things do change with time, 5 years, 10 years, right, is that it's a subgroup of children that have that clear link between craniofacial face and OSA problems. But the majority of the kids do not have that strong link, but a weak link. And so when you put all these kids together in a large sample, the large link, increased link, gets diffused by the smaller link thereafter. So again, the point of this is, it goes back into our current understanding, is that there's not a clear-cut link between a specific facial feature and OSA. But in some kids it goes. And actually, interesting, historically, we have thought about what we call long faces, convex profile kids as the ones that are more likely to have OSA. But when you look into the result of this study, they actually imply more or less of the class 3. So actually, a strong mandible, but a weak maxilla. So I think that's what we're learning. Actually, OSA in kids is not linked only with class 2, long faces, but actually it's also linked with class 3. So fascinating study. It actually reflects the lack of clarity of complexity of the relationship. It doesn't say it exists or not. It only, from my point of view, tells us that there's more work to be done. Okay.
This is a great answer, but right now this our dental or orthodontic world is so divided on a topic. Based on your previous answer, based on the features, early treatment, early orthodontic treatment, what will prevent a pandemic of obstructive sleep apnea for the future generation. And people, on all the conferences, dental sleep conferences, orthodontic conferences, they argue, maybe you cannot do the treatment for little kids. No, you must do the treatment for the little kids. Otherwise, they're going to be sick and tired, and just like us, tired of being sick and tired. What's your view as a practitioner and as a researcher? Both of you on that topic.
Right. So I think that there are different hypotheses, right? And these hypotheses are theoretically possible or not. What we don't have is the proof of the hypothesis. And I think that's the real argument, is just because I have a reasonable hypothesis, it's a hypothesis, right? And probably a better way to answer this will go back into informed consent, right? And so I think we need to be careful not to say do it or not do it is right or wrong. Every patient is an individual, right? And so in a given patient, do something may be justified, but in another patient, do something is not justified. So I will be careful with the concept that there's a debate, and debates are healthy, right? But I don't think the parties should say that you're wrong or I'm wrong, I'm right, you're right. So in a more fundamental level, right, I think that what we don't know is if we have a deficiency, should we act? And then how far should we act? And then in some of the research not related to OSA, when we discuss about class 2 management, with time, what we learn is that by using appliances, devices to facilitate, encourage the mandible reposition, with time, the end result happened to be the same. So in other words, it's almost like we are getting early some of the changes that were going to happen anyway. So I think that the difficult part in this area is to be able to properly differentiate normal growth from the impact of the treatment. So in other words, if we were to treat any kid early, right, the treatment will provide some degree of improvement, but how much is the normal growth part of that improvement? And I think that's where the argument goes. Some will say, well, it's growth, natural growth. The other part is going to say, no, it's the appliance. But going back is I, at this point, will be careful with the concept that we can prevent OSA by doing A, B, and C, because that's a very strong statement, right? And then without strong data, that could be interpreted as deceiving for a family compared to, you know what, as a dentist, as an orthodontist, your kid has a mandible deficiency, for example, or a palatal constriction. So we can decide to do the intervention now, in a year, 5 years, 10 years, right? At this point, right, this is what we know or not about doing it early or not, and then the family makes the call. So I don't think necessarily, therefore, having somebody using like a provider with a kid 3-4 years old using a orthodontic device is inherently wrong. It all goes back into what was the level of conversation with the family, how much the family is aware that there's a lot of uncertainty in the potential impact of this or not. And as dentists, we are lucky that most, if not almost everything we do will not kill a patient, right? In other words, we are able to actually provide care, and I think that at least as a practitioner orthodontist, right? So I can tell you a few times in which I thought I was going to improve something, and then 6 months later, 1 year later, if I actually were to look realistically, without bias, look into the data of my patient before and after, realize, well, I guess I really didn't get as much of A as I thought I was going to get. So we need to be self-reflected, right? And we all have beautiful cases that we can show about how if we do A, this happens. But probably most of these practitioners, if you were to talk with them, they could find also cases in which they provide A and nothing happened. And we need to be more open to communicate our, I will not call it failures, right? But the lack of response of the patient. So things, again, there's no magic bullet. Things don't work, there's no approach. So my concern maybe as a practitioner becomes, how do I go ahead with a treatment that may help or may not? How do I communicate that? And sometimes, even when I tell my families of my patients, you know what, there's a very small chance of this actually be really meaningful. They want to go ahead. They want to pay for it, then it's okay, because I have completed informed consent. And then when things work, everybody's happy. And if they don't work, I feel okay. I told you it may not work. You decide to try. I think that's a little bit, Maria, where I think that it's more realistic in practice is how you present information will be more my concern, more than this site is right, that site is wrong.
No, this is a very practical view. And just like you mentioned in our previous conversation about training, I don't want to quote your words, but, we train totally different from medical doctors. If you can reflect on that, in addition to the advice of the orthodontists who graduate from your program or any other program with, one point of view, and now in outside world, thank you to social media, there is a different point of view, how they should act when confidence level is not very high.
Right, and then there's a personality thing. So I consider myself a conservative provider. That's right or wrong, it is what it is. And so I tend not to jump into new novelties in clinical practice as soon as they come out. I am more comfortable. Let's wait for 5 years, let my peers try it, and it's working, then I go in. But that doesn't mean that those that actually jump ahead and do things are wrong. It just means that you need to understand where do you fit and practice the way you feel comfortable, right? And I think that is, again, it's getting very, very common now, and it's a very tricky conversation when you have a patient come for a second, third, fourth, fifth consult, right? And then how much do you reflect your thought process without bad mouthing or saying that the other person is wrong? We don't know who's right and who's wrong. That's a reality, right? And so again, you have to be professional, not saying my way is the way compared to the way I look into the world is this. That's another way to do it. You as a patient need to decide which provider you feel more comfortable. And then if you're not comfortable with me, please go back to the previous provider. Life goes on. That's what we're learning. That's what we're trying to teach the students. It's just, it's tricky when you want to maintain the patient, but then there's a mismatch between the expectation of the patient and your expectations. If they don't match, don't treat. Let somebody else treat the patient, and everybody will be happy that way.
Thank you very much, Doctor. I really appreciate that practical opinion, because I have to admit it's very easy to proclaim everything on the lectures, and it's very different when you face to face with the parents who wants the best for the kids, with the patient.
And Maria, those parents are having kids with OSA. It's an extremely difficult scenario because there's so many different opinions between the physician, the ENT, the nurse, the dentist, the orthodontist, the pediatric dentist, and the poor parent is in the middle. And we have a lot of power, because if I were to offer the patient, if you use this, we are going to solve your problem, they are going to pay anything I ask for that. So we have too much power, and then there. So my concern again is informed consent. How do you phrase it in a way that's fair for all the involved parties? Because these parents will pay anything that actually gives them the hope that this will solve. And I'm not saying don't do it, but then between hope and reality, there could be a lot of difference, right? So that clinical uncertainty, it's large in this area. So let's be careful how we phrase our conversation with the patients, and then work together to work with them to the solution, hopefully, of a problem.
Thank you very much. And I really appreciate, what you mentioned, team approach, and you mentioned there is no perfection, and we're not psychic to see in the future, because that's what's expected from us. Actually, I think it's a lot of wisdom. Thank you very much, Doctor. I really appreciate those words, what actually reflect the present state of science.